So today we're going to be starting our chapter 10 um, lectures. Now, the kidneys, it's a huge chapter. And so I'm going to separate these lectures into three. So we're going to be lecturing on the kidneys for 3 weeks because it's so large. There's so much information. I just want you to be able to like zone in every week on a certain amount of information. So here we go. There, look how big this chapter is. And so you have to kind of sift through all the information to what is important for you guys now. So that's what I'm going to try to like kind of zone in on today. Okay, so a little bit that you should know from your anatomy physiology class is that most normal people have two kidneys. The kidneys are located in the retroperitoneum and lateral to the vertebrae, and they produce urine. There's also two ureters, one coming off each kidney. And the ureters transport the urine from the kidneys to the bladder. One bladder stores the urine, and the urethra is the little tube that drains the urine from the bladder outside the body. So that's your urinary system anatomy. So what we do with the urinary system, and we kind of talked about this in our lower urinary system chapter, but we're going to expand now into the kidneys, is we are going to evaluate the renal and juxtarenal tissue. We're going to identify, assess the renal length, width, and thickness. So we're going to make sure they're not too big, not too small. We're going to demonstrate the appearance, size, and echogenicity of the renal capsule, the cortex, the medulla, and the sinus. And we're going to differentiate between solid and cystic lesions. That's a huge thing. So there's a lot of embryology um, talked about in your chapter, and I think it's really good for you to know. But I'm going to talk about what I feel like you should know at this point. And one of the things that is really interesting is with embryology at the 8th week, the embryo, the nephron functions begin. So in the first trimester, the kidney function begins. And the kidneys begin to migrate from the pelvic location to the abdomen at this time. The kidneys in infants and young children are located more caudal, and migration is not complete until 5 to 6 years. So they keep on, the kidneys keep on migrating up towards the liver and spleen into 5 and 6 years of a kiddo. So they're going to be lower if you're scanning pediatric kidneys. So the kidneys are about the size of a tightly clenched fist. They're approximately 10 to 12 centimeters. Sometimes it can be up to like 9.5 too, depends on the size of the patient. The width is 5 to 7, and the thickness is 2 to 3 centimeters. They're about 130 to 150 grams. Typically, we want to see both kidneys within 2 centimeters of each other. So if you had one kidney that was 7 centimeters and you had one kidney that was 13 centimeters, that would be a hint that something might be going on with the kidney that is smaller. They're brown organs, and they're convex lateral borders and concave medial borders. So they're round in the lateral and more concave in the medial. The medial border is going to be the renal hilus, and the renal hilus leads to the renal sinus, and the renal sinus has the blood vessels, lymphs, nerves, and ureter. So that's going to be like the medial portion of the kidney that contains everything that enters in and out of the kidney. So these are the typical location of a female here. The left kidney looks a little bit higher, close to the 11th and 12th rib. Um, right kidney is a little bit lower, but still protected by those ribs there. Both ureters are coming down to the urinary bladder. And then you can see the urethra there. So when I'm talking about the renal sinus, I'm talking about the part of the kidney where the veins and arteries go into. So that's the renal sinus. That's in the medial portion. One big thing that you need to know is that the kidneys are located in the retroperitoneum along the posterior abdominal wall. There's 3 layers of supportive tissues surrounding the kidney, the fibrous renal capsule, which is the innermost. Then you have an adipose capsule and the renal fascia, which is the outermost. The renal capsule covers the surface continuous with the outer layer of the ureter at the hilus and gives a kidney a glistening appearance. It serves as a barrier against physical trauma and infection. So, how the kidneys are placed, they can be injured pretty easy. And so, you want to make sure, like this renal capsule, is trying to help protect it. The adipose capsule kind of holds the kidney in place and cushions the kidneys against blows. And the outermost renal fascia is the connective tissue that surrounds it and the adrenal gland. And it completely encloses the kidney and anchors the kidneys. Here's a transverse image of the kidney. You can see here the renal artery and vein going into the renal sinus there on each side. You can see there's a lot of the renal fascia, there's pararenal fat around to protect the kidney there. And then the renal capsule. So the body really tries to protect these critical organs. The location and size, the renal vasculature and the fatty encasement holding kidneys in normal position, and kidneys move 3 to 4 centimeters when changing from supine to erect, which is crazy, because they move down quite a bit, but they shouldn't move down too much. So let's talk about the relationship of the anatomy. So when you're scanning, you're going to find one thing that you're going to find on the right kidney is that it's located, we use the liver as a window to see the right kidney a lot because the hepatic area of the kidney right here, the right kidney is underneath the liver quite a bit. So it's close contact with the liver. So we'll see both the right kidney and liver in our images of the right kidney. On the left side, you're going to not see as much spleen as you would liver, but the splenic area of the left side they're pretty close, but not as much as the right. So you need to know a little bit about renal vascularity because there is this sonographic exam that we do called a renal artery Doppler, where we're looking for occlusions um, or some kind of stenosis that's causing high blood pressure in the patient. And so we look at all of these different arteries. So it's important for you to know all the different arteries. So the renal artery is going to go into the kidney. And then you're going to, within the renal sinus, there's going to be branches called the segmental arteries that then branch to the interlobar arteries that are between the pyramids. And then at the base of the pyramids, the arcuate arteries course to the medulla. And then the final branch is the interlobular arteries. So I want you to know those 5. And then there's little afferent arteries, the glomerulus, And I'll show you a really good picture because this can get kind of confusing, but I want you to like really look at these two images here. So this is the renal artery going in there, and then you see all the branches of the renal artery. Um, the renal sinus is what we call the where the ureter, artery, and vein all enter into. So then these little triangle looking things, those are the medullary pyramids or the renal pyramids. The cortex is going to be the outer part of the kidney, and then the renal capsule covers it. And so these arteries are going to be branching off between these through the sinus, through the pyramids and the medulla, into the cortex, which is the outer portion. So this is a picture of the renal artery starting, and this is how the blood flow goes. So this is what I want you to know. The aorta to the renal artery, to the interlobar artery, to the arcuate artery, to the interlobular artery, to the afferent artery, to the glomerulus, to the inferent arteriole, to the peritubular capillaries, to the interlobular vein, to the arcuate vein, interlobar vein, and renal vein. So that's how the vascularity of the kidney goes. So I want you to know that. The ones we look at usually on the renal Dopplers that we do are going to be up to the interlobular artery, which courses through the cortex of the kidney. Here's another image of the anatomy of the kidney and what it looks like on ultrasound, which is this is the huge thing. This is the thing that you guys really need to know. So the renal pelvis or renal sinus, this is going to be where the ureter, the artery, and the vein all come into. So this could be the most echogenic part of the kidney. So then from there, you're going to get the medullas. The medulla are these little pyramid looking veins that are like more anechoic, little black triangles. And then the cortex of the kidney is going to be more of the hypoechoic outer portion. So you can see what it looks like on the left side of the screen versus what it looks like on the right side of the screen on the ultrasound. The calyces are the echogenic portion that extend into the medulla, which is the anechoic pyramid areas. So the sonographic appearance of the kidneys, this is the echo amplitude of renal structures in ascending order. So the renal medulla, which is the, looking back here, the like anechoic area right there, is the most hypoechoic anechoic area. Then next to that, the renal cortex is the next hypoechoic, which is the outer edge of the kidney. Then from there, the liver, then the spleen, then the pancreas, then the diaphragm, then the renal sinus, which is the inner portion. You see how echogenic that is. That's the most echogenic portion. So that's what that's kind of talking about. So the renal capsule is the strong, continuous, linear specular reflector surrounds the cortex. So that's like this area. It's like echogenic right there. The renal parenchyma resolves into more echogenic outer cortex from hypoechoic inner medulla. So what it's saying there is the medullas are the darkest part of the whole kidney. And then the cortex is more hyperechoic than that, but it's still pretty dark, right? Compared to the sinus or renal pelvis. The renal medullas are rounded or blunted geometric hypoechoic zones, best demonstrated on coronal sections. This, see these little anechoic medullas The corticomedullary junction, recognized by the columns of Bertin extending inward and arcuate vessels. That's talking about the calyces here. In between each medulla. And the renal sinus is the index compact zone of the central homogeneous echoes within the kidney sinus, having an echo amplitude equal to or greater than that of the renal capsule. So what they're talking about there in terms that are easier to understand is all this bright area here. This is the renal pelvis, renal sinus. Here's another image of the normal kidney, and the arrows on the left picture are pointing to the hypoechoic renal pyramids or the medulla. The C is the renal cortex, and the S is the renal sinus. This is showing the left kidney, and the arrows pointed here pointing to the renal capsule, which is echogenic, that surrounds the kidney. Here's a transverse portion through the right kidney, showing the right renal vein going in, RRV, and the ureter. And you can see how bright it is where the veins and ureter go in. And again, that's the renal pelvis, the renal sinus. Here's another image of the right kidney and transverse with the right renal artery and the right renal vein going into the right kidney. You can even see, this is a gorgeous picture of showing the right renal artery all the way to from the aorta to the kidney there. Look how vascular the kidney is. And this is just when you put color flow on, you can see all those segments that we talked about. So there's a couple of things with the anatomy. There's going to be anatomic variations. There always are. But there's a couple of them that you need to know so that you don't call it a mass when it's not. And one of the most common ones that I always see is a dromedary hump. And usually on the left kidney, I feel like I see it more. And basically what it is just like a hump, like a camel's hump. And this is just a normal variation. And I'm sure when you guys start scanning kidneys, one of you guys will probably have a dromedary hump because it's just that common of a variation. So if you see like an extra hump, like a camel, don't freak out and think it's some kind of mass. Put color on it, see if there's any distinction, difference between the rest of the renal cortex. And if there's not, I would say on my report, possible dromedary hump seen. Another thing that you might see is a junctional defect, where there's an echogenic area where the cortex should be. And that is just an anatomic variation. The final thing that you'll see quite a bit is called a hypertrophic column of Burton. And this can also kind of trick you up because you're looking for masses when you're doing the kidney, and you're looking for cysts and you're looking for pathology. And so when you see something like this and you're looking and you see that the renal sinus is being not continuous due to an extra hypoechoic area, it makes you think that potentially this could be some kind of pathology, but it's usually just a extension of the cortex called a column of Bertin. And that's what this arrow is pointing to on both sides. So you can see how it extends into the sinus. You can also get what we call like an extrarenal pelvis, and that's a transverse sonogram through the midpole of the right kidney. Um, that demonstrates a central anechoic area outside of the renal pelvis, but communicating with the right kidney, consistent with the extrarenal pelvis. So if you see something like this, um, you would definitely want to note it that you're seeing an extrarenal or some kind of anechoic cystic region outside of the kidney going into the kidney. But this is what most likely it's going to be. So a little bit about the vascularity. So the arteries, the renal arteries are identified entering the hilus posterior to the renal veins, posterior to the renal veins. The renal arteries are not visualized as frequently as veins. Veins are always visualized. And I can't wait for you guys to start scanning and putting color on because you're going to see the renal vein really easy. The right renal artery is longer than the left renal artery, and that um, is possibly because, or is because the aorta is located on the left side while the IVC is located on the right side. So the right renal artery has to travel longer to get to the right kidney. And another important part of anatomy is that the right renal artery courses posterior to the IVC. The renal veins are visualized at about the same level as the renal arteries. The right renal vein, its size is altered by respiration and transmitted pulses from IVC. The left renal vein can be seen coursing between the SMA and the aorta to enter the lateral aspect of the IVC. You remember the nutcracker phenomenon? We're talking about that again. That's narrowing of the left renal vein between the aorta and SMA. Prominence of the left renal vein and incompletely imaged normal aortic wall adjacent to the vein may give a false impression of a left renal artery aneurysm. In a patient with renal cell carcinoma, determining patency of the renal veins is an important aspect of staging disease. So, if you are dealing with that, you will know and you'll be looking at the vascularity a little bit more than what we would do on a normal kidney ultrasound. So I'm not going to go into all of the microscopic anatomy because there's quite a bit, but one thing I want you to know is the nephron. And the nephron is the kidney's basic histology and functional unit. So you need to know the nephron. That's what makes the kidney work. The cortex and the renal pyramids together make up renal parenchyma containing nephrons, and each kidney contains up to 1 million nephrons. And it consists of these: a renal corpuscle, a renal tubule, and a vascular component. So where are both kidneys located at? In the retroperitoneum. Approximately 75% of which surface comes in contact with the right impression of the visceral surface of the liver. And it is the anterior surface of the right kidney comes in contact with the liver. Which vascular vessels are arching branches coursing between the medulla and the cortex, parallel to the kidneys? Those are the arcuate arteries. The narrowing of which vessel located between the aorta and SMA should not be mistaken for a pathological change in the left renal vein. All right, we're going to talk a little bit about physiology now. So what does the kidney do? It removes waste from the blood and regulates blood's fluid and electrolyte content. That's very important. Each minute, 20 to 25% of the total cardiac output is transported from the right renal vein and left renal vein, or right renal artery, left renal artery through the kidneys, which is crazy. And 90% of the blood entering the kidney perfuses the cortex, which contains the nephron. Only a small amount of blood supply kidneys supplies the kidneys needs. So all that blood going in and why it's so vascular is because the kidneys are filtering it all out so that we can have good, clean blood. Kidney function is both excretory and regulatory activity, processing 180 liters of blood derived fluid daily. And so of total amount of blood derived fluid circulated through the kidneys, 99% is filtered and returned for circulation. About 1% is eliminated from the body as urine. So when I was talking to one of my students, there was a wow moment when she had thought that so urine isn't just the liquid that we drink in our stomachs, that it's actually the blood that is filtered out through the kidneys. Isn't that crazy? And so I think a lot of people think that the fluid that you drink in your stomach like goes to your stomach and just goes straight down to your blood. If they do not know much about anatomy and physiology, there isn't that disconnect. There is a disconnect that what is actually is going on in the body. So the water is circulated through the GI tract and into the blood, and the blood goes into the kidneys, and the kidneys take care of filtering out and creating urine. But it's actually the urine is created from the blood, not the water that you drink or the stuff that you drink. Makes you want to drink your water every day. So the 1/3 of nephrons must function to ensure survival. So 1/3, 1/3 is what you need. Three important nephron functions are controlling blood concentration and volume by removing selected amounts of water and solutes. So they have to be perfect, which is amazing. The body is just crazy, just so amazing. Helping to regulate blood pH levels and removing toxic waste from the blood. What percentage of nephrons must be capable of producing urine to ensure survival? 33%. So you're going to do ultrasounds for patients that have abnormal renal function tests. And we need to know a little bit about what renal function tests are. So the sonographer should have a basic understanding of normal and abnormal values to correlate clinical history and presenting symptoms with sonographic representation of anatomy, disease, and pathology. So urea, nitrogen, creatinine, and uric acid are used to evaluate the renal functions. Normal values vary by sex, age, and geographic region, which is interesting about geographic region, right? But your first one that you need to know about is the blood urea nitrogen, or BUN. And this measures the amount of urea nitrogen in the blood. And urea, an end product of the protein metabolism, is formed in the liver and carried to the kidney for excretion. So BUN can be used to measure renal function. Creatinine is a non-protein end product of breakdown of creatinine phosphatase in the skeletal muscles. Creatinine is removed by the glomerular filtration. Rate is close to serum creatinine production. Is a very accurate test since creatinine production is not affected by protein intake, urine volume, hydration, or protein metabolism. If only one kidney is functioning, the opposite kidney, if normal, increases filtration rate. So we look at the creatinine level. And uric acid is the end product of purine metabolism and is from the breakdown of proteins. You look at the red blood cell count, white blood cell count, and differential white blood cell count. Hematocrit, lactic acid dehydrogenase, urine pH, and specific gravity of urine. So which of the following is used to measure renal function? It's uric acid. So the big thing I really wanted to concentrate on is sonographic scanning technique. So that's what you need to really know. So for a kidney evaluation, no patient preparation is required. Um, Fasting always helps though, and so a patient, if they cannot eat, is going to help. Um, so for kidneys and surrounding structures like adrenal, pancreas, it's recommended to 6 to 8 hour fast, but you can do a kidney ultrasound without fasting and you can still see pretty well. The other thing that I'd like to do is make sure that the patient drinks quite a bit of water. So that'll help us evaluate the bladder and ureters too. The native kidneys can usually be assessed by patient in supine, posterior oblique, or lateral decubitus position. So for usually the right kidney, I will keep the patient supine or roll them a little bit onto their left side to see that kidney. For the left kidney, I usually do a left lateral decubitus or a right lateral decubitus where the patient's left side is up. The minimum routine examination include long sections, renal length, evaluate kidney from lateral to medial margins, and transverse sections, superior pole, mid kidney, imaging renal artery and vein, make measurements, and inferior pole. So what I usually do, and we will give you the protocol for what Newman does for a kidney ultrasound, but it's usually a midline kidney. Then you take that measurement. Then you go to the lateral kidney, and then you go to the medial kidney. Then you do transverse images, two superior, two mid with measurement, and then two inferior, and then put blood flow on the kidney, and then you'd go to the left kidney and do the same thing. And then you look at the bladder. The liver is a good acoustic window for the right kidney. And as we had said, that the right kidney anterior surface connects with the liver. So the renal arteries and veins are best visualized in a transverse plane and a perpendicular relationship to the sound beam. The right renal vessel is best imaged with transducer placed transversely over the right kidney. And the left renal vessels are best imaged with the transducer in a transverse orientation midline of abdomen. So what you need to get out of that is that the veins and arteries are better visualized in the transverse position because you can really see them going into the renal sinus. If the patient is in a prone position, you can use pillows or rolled sheets. I don't usually scan in a prone position, but you can do that and look at the kidneys from kind of the back side or lateral side of the body. So the accurate bilateral kidney length, width, and thickness measurements are obtained in routine procedure, and renal measurements are dependent on multiple different things. So age, body habitus, sex, and hydration actually even makes a difference. So hypertrophy usually follows removal of one kidney due to disease, injury, or transplantation. So that basically means that let's say the patient doesn't have a left kidney due to something, and the right kidney is going to be bigger because it has to work. Because remember, we need 33% of the nephrons to work to filter the right amount of blood out. Best correlation of renal length is body height, actually. And the adult cortex is generally more than 1 centimeter in thickness over the pyramids. And I want you to know that. And you guys remember what the cortex is that hypoechoic outer area. Here's a beautiful image of a right kidney measurement, and you can see how much the liver is covering the kidney there, right? And here's a transverse image of it. Beautiful images of the kidney there. And that's, I'm sure, what you guys are going to, your kidneys will look like too. Here's the left kidney. And you can see that the spleen is not covering the left side as much, that the left kidney is out kind of on its own a little bit more, but you can see a little bit of the spleen on the left side of the screen here. Transverse images are kind of oblique, not straight up and down, because of how the left kidney is within in the body. So you don't go off a straight transverse plane. You go off a transverse plane of the organ that you're looking at. So when we decide to go ahead and do Doppler examination, the patient is positioned in posterior obliques or decubitus, and then we want to look at the segmental, interlobar, and arcuate vessels. The velocity measurement should be made with a Doppler angle of less than 60, and that's for everything with vascular. If it's greater than 60, it could lead to falsely elevated velocities, which we don't want. So what does the pulse Doppler do? It's helpful in assessing peripheral artery resistance, hydronephrosis, or other renal disease. Color Doppler is used to evaluate occlusion, stenosis, or aneurysm. And Power Doppler just helps demonstrate the entire renovascular tree. So you can see it all the way up to like the very small arteries, the afferent arteries, arterioles. So on a normal kidney ultrasound, you're just going to put color Doppler on there, and you're going to keep it at that. You're not going to start doing pulse Doppler unless you are doing a specific renal artery Doppler exam. Then you're going to start doing pulse Doppler of the renal artery, the aorta, and the very small vessels going into the kidney. So let's say you're doing a renal artery Doppler exam for unexplained hypertension. You're going to set the wall filter as low as possible. So you're going to get low velocities that way. Minimize error and maximize Doppler tracings using small PRF. And you're going to evaluate the vascular and parenchymal disease, examining intrarenal vessels, and they're going to be the segmental artery, which is in the hilum. And then the interlobar, that's going to be at the border of the medullary pyramids. And then the arcuate is going to be your last one, and that's going to be at your cortex medullary junction. So when you're doing this, your computer, you're not going to have to come up with the R resistive index by yourself, but the computer will come up with an RI. And what you need to know is that an RI of greater than 0.7 could potentially mean there's some kind of stenosis going on. Usually the RI is going to be 0.58 to 0.64. Greater than 0.7 distinguishes renal obstruction from unobstructed dilatation. Here's an image of that. And so this is what your computer is going to come up with. So you're going to put, it looks like they're looking at the arcuate artery there because look how close it is to the cortex. And so then here are the Doppler signals of that arcuate artery. The sonographer is going to measure that systolic peak of this, and then also going to measure the diastolic peak, which is the lowest portion of the Doppler signal. And then the computer will come up with these two velocities and then calculate an RI for you. So don't worry about calculating the resistive index. But you can see from here that the resistive index is 0.84. So that kind of makes us think that potentially there could be some kind of occlusion going on. This is a beautiful image of pulse Doppler or a power Doppler, and you can see how gorgeous. You can see with power Doppler how beautiful. Um, you can see all of the little branches of the arteries going through there. So there are some technical considerations when scanning. For kidney visualization, a deep inspiration pushes liver, spleen, kidneys down about. So you're going to sometimes want the patient to hold their breath or take a deep breath, depending on you're going to be working with a couple of ribs there. So I usually have the patient take a deep breath. There's some pitfalls with scanning. So the normal kidney is an anisotropic organ, which means that's a fancy word for meaning that the appearance of it is based on the sound beam. So when you're doing a sagittal image of the kidney, it's going to look like a darker image than when you're doing a transverse section of the kidney. It's going to be more echogenic. And you guys can, when you start scanning, you can see this on your own. So respiratory motion or failure to visualize true long axis of the kidney can lead to underestimation or overestimation of the renal size. So you want to make sure that you are really midline when you are doing a sagittal image of the kidney and you're not cutting the kidney off. Patients that are athletic or young men have hypertrophic psoas muscles that can simulate renal or adrenal tumors. And what I'm talking about here is they just have really strong muscles. And so this is the psoas muscle. So if you see that, it's not necessarily a mass, but a muscle. Now, how can you differentiate this? You can, in a supine position, you can flex or pull the legs up with a muscle contraction, and anatomic structures close to the kidney's upper pole can simulate masses arising from this region. Adrenal glands, liver, spleen, pancreatic head, pancreatic tail. But when you have the patient flex or pull up, you'll see the contraction. And if you see that, you're going to know that that's a muscle, not a mass, because mass is not going to contract like that. Another really difficult thing that you will learn in your career is that when there's a trophic kidney, it's really hard to see. And sometimes, if a patient has renal failure, it's really hard to outline. Um, and the more that you get exposed to kidneys, the more easier it'll be to see. But there was times in my early career where I was freaking out because I could not find the kidney and they had to have a kidney. And so what I would end up seeing is this really faint little atrophic kidney. And we'll talk more about that in the next couple of lectures. Another interesting thing is when a patient has an overextended bladder, it can come off as dilatation of the renal pelvis or hydronephrosis. So this patient is showing that long transverse images, and you can see RP here. That's the dilatation of the renal pelvis going into the sinus there. And you can see how big the bladder is. Now, you can be like, okay, why don't you go to the bathroom? And then after you scan, look how the kidney looks now. You don't see the dilatation of the renal pelvis. It corrected itself, and that's because it was a false positive it's called pseudohydronephrosis, and that's due to overextended urinary bladder. So you want to see if you see renal like dilatation or hydronephrosis or something like that, and a very full bladder, have them go empty. And so you can make sure that that's real. An ectopic or transplanted kidney can be confused as a pelvic mass. So, like a horseshoe kidney, which we'll talk about in our next lecture. But if there is a kidney that does not migrate from the pelvis to the retroperitoneum, and it stays down there, it could be a pelvic mass, but it's actually the kidney. So if you don't see like a left or right kidney, then you go look in the pelvis and you could potentially see it there. Rib artifacts. I know that you guys have been scanning the liver, and so that ribs can get in the way and cause a lot of issues. So, what term describes why the appearance of the organ varies based on the angle of the ultrasound beam? It is anisotropic. What type of artifact is due to refraction of the sound beam occurring at the tissue fat interface? Sorry about that. It came out. But that's actually duplication. Okay, so I think we are going to be done for today. Next lecture, are going to work on congenital anomalies, and we're going to go all the way down to probably trauma here. And then the next week, we'll do renal infection down to other imaging procedures. So I feel like we got a lot done. If you have any questions, just ask me or write in your discussion. And this week, we're going to be doing a presentation where you're going to do a PowerPoint presentation on what a kidney looks like on ultrasound and the vascularity of the kidney. So, all right, have a good week.